Good afternoon. Welcome to our symposium. We are having a discussion this afternoon on improving patient-related outcomes through value-based wound care. My name is John Timmins and I'm the Director of Medical Affairs here at Molnlycke Healthcare. And I'm going to introduce a few of our speakers now. I'm joined on the stage with Gulnaz Tariq, who is the President of the World Union of Wound Healing Societies. Welcome, Gulnaz. And also Bill Padula, who is a health economist from California, who is also the president of the National Pressure Injury Advisory Panel from the US as well. So welcome, Bill.
Thank you.
Good to see you both. I'll just go through our other presenters as well. So we have Mohammed Bazini, who's a local vascular surgeon. Professor Bazini has been someone who actually did some of his training in the UK, so I've known Mohammed for a while now. We have Kimberly DeSanto, who's the sourcing lead for the Mount Sinai Health System in New York. And we also have Jamel Geraghty, who's a nurse specialist and lecturer from London in the UK. So we have a lot of people from a lot of different places, so you'll know now why it's been tricky to get everyone in the same place, speaking at the same time and listening to each other. So hopefully we can have a good session. Just our usual disclaimer about what's being done here. So just as to get a little bit of a feel for who's here, who's in the audience today, we have a couple of Mentimeter questions, so if you want to look on your phones, go to menti.com if you can. And if you enter the code 80187976, we should have a couple of questions for you coming up. So what role do you play in wound care delivery? That is one of the questions there. So can you answer that question on your Menti now? Just so we can get an idea of who's in the audience today. How are we doing with the technical components down there? All good? So it's 80187976, if you don't have the code. 80187976. So far we have 2 people.
I see more than 2 people in
There's
the
definitely more than
audience.
2 people out there, I think, Bill.
We need the code again.
So 80187976. And if all this fails, I'm going analog and getting a show of hands. Okay, we're going analog. So how many are hospital leaders in the audience? Hand up, you're a hospital leader. 2, 3, okay. How many doctors in the audience? Okay, we've got about 10, do you think, Bill?
Yeah, I saw 11.
Okay, and he's a health economist, so he's got the say in this one, I would say. So, and, any purchasing people? No purchasing people. That's interesting. We need to get more of these guys along. Any nurses in the room?
Wow.
Oh my.
I can't.
quite a
You
lot.
can't count now.
I'm switching. Yeah, I'm switching to Bill for this one. How many nurses is that, Bill?
87.5.
Wow. Have we got a range of error there? Are you okay?
87.5 plus or minus 0.3.
Nice. And so, we have any other professions with a passion for wound care? Oh,
Economist.
one here.
Economist.
Okay, a couple in there. And any podiatrists? Just one podiatrist.
No more.
Okay. Wow, I thought we'd have more podiatrists actually, but yeah. Well, thank you for that. So, given that we're going analog, is the concept of value new to you? Stick your hand up if value is a new thing. You've not thought about value before. I thought Joel was putting his hand up there, but he's... So everyone thinks about value then. Do you say that it's something you think about every day? Put your hand up as value is something you think about every day when you're working in practice. So some of you don't actually, so interesting. Let's see if we can change your mind today then. So if we can switch then to the guys online. Hello and welcome again, everyone. Good to see you. So I've got a few questions here. We asked some of the Molnlycke employees, we asked some of our nurses that we work with, about value. And so I'm going to ask this same question to you all, because all of you have got different approaches, you have different jobs, you do different things in healthcare, and so you all have different ideas about what value might mean. So I'm going to start with the people I have here with me. So Gulnaz, what does value mean to you?
For me, value means that I see outcome and patient comes first. What is good for patient doesn't give him pain, quality of life, didn't really mess around with all this. So that's my value. So patient is comfortable, adhere to it, and comfort level is great, and its purpose is fulfilled, and outcomes are there. That's my value.
Okay, thank you. So it's about the patient, basically. It's about them being comfortable. So, because it's interesting, we had some discussions earlier in this room with the previous session that it's not always about healing that's important, it's about how you get there, isn't it? It's more about that patient worrying every day about pain, they're worried about leakage, they're worried about odour, and we need to deal with all those things as well as try and heal the wound, and I think all of these are important. Bill, what about you? What does value mean to you as a health economist?
I think that the video did a nice job to give you a foundation for the understanding of value. Frankly, that, of course, most people start with just this idea that value is about cost, it's about saving money. But value is, as Gulnaz put it, about cost relative to the outcomes. Outcomes is a very general term, though, right? In wound care, there are so many different kinds of wounds, and the goal of a good outcome changes. With pressure injuries, it's about preventing them altogether. So what is your incidence rate? With diabetic foot, it might be about number of ulcers and extremities, or it might be about avoiding a severe outcome like amputation. So translating value into a specific definition depends on the wound itself, and thinking creatively about what outcome you can communicate to a decision maker in order to make them invest in your practice.
Perfect, thank you. So I'm going to ask you, Mohammed, sorry you couldn't be here today, but I hear you had a negative test, which is good, and hopefully you can be here on Friday. So what about value in you? You're a vascular surgeon. What kind of things do you think about in terms of value in your day-to-day work? Oh.
Let me just explain that from a surgical point of view, value to me is a mind shift, not just the clinicians, but for all. So the hospital providers, the suppliers, patients. And it's more about shifting our concept, as Bill just mentioned there, from the idea of cost and just cost effectiveness alone, but looking at what matters to the patients. And sometimes we don't even know what the real outcome measure that a patient considers to be value, compared to what we might do. I mean, you might look at mortality rates and think that's the actual endpoint that we should be focusing on. But in fact, yes, it is important, but in fact, it might be the quality of life, the ability of a patient to walk, and other outcome measures that if we don't look at it, then the patient doesn't necessarily get value for money, and the healthcare system doesn't get value for money as well. So it is a complete mind shift, and we have to get away from just concepts of volume and concepts of cost as a silo mentality, and bring together that outcome and how much cost it requires to get you that out. That's my view.
Thank you.
Thanks.
And if I go back to you, Jamel, Jamel, you've worked in various different sort of areas of nursing, if you like, almost always involved in wound care of sorts. I know you've worked with homeless, you've worked with many different sort of parts of society in your role. How does value come into that? If you're looking after patients every day, what is value in that respect?
I mean, for me, value-based wound care is very much, as Gulnaz said, around being person-centered. So, I think we need to invest in the individual, what matters to them. And then there's this ripple effect. So if a patient understands their condition and can have engagement and make choices about, for example, a venous leg ulcer, then they're more likely to wear their compression, come to their appointments. Ultimately, healing's likely to improve. You have less wastage of dressings. But, unfortunately now in this day and age, we're talking about no time to do anything. And I really challenge that concept because I think there's plenty of time. I think we just don't use time wisely. So for me, value is all about investing time wisely into the people that we care about. And ultimately, the outcomes are person-centered.
And cool. So Kimberly, last but not least, you're involved in purchasing, procurement, sourcing, and supplies. What is value to you? You've got to think about the bigger picture. So can you explain to us what value means and how you make those decisions?
Yes, and as a nurse, when I was bedside or as a leader, I had different goals. We always had the patient at the forefront, but we weren't aligned with what the hospital organization maybe was looking for. So I feel value for me now in my current role, since I am a clinician, is trying to improve the patient care while trying to make improve outcomes and also reduce cost, but show how we could make it better for the patient and for the clinicians. So that's how I try to bring value. We try to look at evidence-based to see what products are out there or what supplies or what practices and how could we bring it to the bedside and trying to get, everybody aligned with what the goals are. It's difficult when you report to the financial leadership of the organization. You need to tell your story of why this is important. The leaders do try to, we all are trying to reduce the negative outcomes. You just need to tell the picture of why this is important for all of us. So that's value for me is, bringing it to the bedside, improving the patient outcomes, decreasing the negative outcomes for patients.
Thank you very much. Bill, Kimberly said something important there. It was about the language she used.
Let me touch on what both Kimberly and Jamel said that I think is really important here, and it has to do with patient-centered care. I don't need a calculator to know that is what's best for the patient is a pressure injury avoided, or a shorter healing time of a venous leg ulcer, or avoiding an amputation that would have otherwise happened with a DFU. So finding an efficient pathway to avert those complications and improve wound outcomes that way is the best value added possible. And you don't need a calculator to figure that out. You don't need to worry about cost, because as long as we're delivering value to the patient in terms of improved outcomes, then the cost necessary to get there is worth it.
Kimberly also mentioned the way she has to phrase these decisions to the people upstairs. You mentioned this morning in one of the discussions we were having in the Hive. Can you expand on that language you need to use to if you like, talk about value?
Value comes in many different forms. Like you've heard here, Mohammed say value for money, or thinking in terms of what is the dollar value relative to some improved outcome. The thing is, though, that money can be calculated differently. We have a number of different measures, in fact. There's cost effectiveness analysis, and you see a lot of that is translating costs relative to clinical benefits. That's usually meaningful to, let's say, a chief medical officer, a chief nurse officer, because they like to think about the cost relative to what is the improved outcomes and benefit for the patient. But for somebody like a chief financial officer, their responsibility is to make sure that a budget is well managed year to year for a facility so it doesn't go out of business. It's an unfortunate reality that we live in managing health systems, right? That health systems have to be run like businesses so that they sustain themselves. And so in addition to cost effectiveness analysis, there's budget impact analysis that I think is more translatable to payers and chief financial officers. And there's also return on investment, thinking in terms of if I spend money on something that is preventive or delivers better patient-centered care today, that I might actually have more money in the future by avoiding paying for costly complications like pressure injuries, so that I can spend it in other places in the future. And I see it as starting with a strategy for quality improvement and wound care, wherever that may be, pressure injuries, DFUs, and so forth, we can actually conserve finances and find ways to spend it in other areas of priority in the future.
Excellent, thank you. So if we take that on to the next stage then, which is about how we implement that, Gulnaz, have you got any examples of where you've kind of implemented change that's both improved outcomes and also given you value for money?
Yeah, definitely. So when we started, 10 years before, to do the prevention strategies in our facility, and not only in our facility, we transformed that into 7 other facilities as well. So we were collecting the data, like we were having the incident reports for monthly basis, then we were doing the NT-NQI on a quarterly basis, then we are doing a prevalence study on a yearly basis and evaluating ourselves, what is our data telling us. So data collection was really a key for me to take my case to my procurement, that this is my data and this is what I want. So, to giving them evidence where I'm coming from, and then to, implement what I want for patient-centered care, what you have mentioned. So my case was strong because I was having the strong data. So anything you do is, what I feel is, you need to have your homework done with the data, and then that will support you. So if I have, let's say, for a month, 100 high-risk pressure injury patient, which I prevented it, but then there is one which happened, so I need to, take my case to the procurement and leadership. So the buy-in has to be from top to the bottom, to the bedside, and then, the professionals who are working on the wound care, especially nurses, because they are the ones who are taking these things, and obviously physicians as well, we need to work together to see how we can make our case strong.
Yeah, I totally agree, and I think that we're going to hear a lot about data at this Congress. I think there's a lot of sessions which talk about how we can use data to help our case, but also how we can properly measure outcomes. Bill, you mentioned it this morning as well, didn't you, about measuring and being able to prove a case using data?
Yeah, data collection is so important to understand the numerator of what was showed in that video. Cost is easy to calculate, whether it's reimbursed or not. But with outcomes, you have to be very thoughtful of the data. I actually have a story I'll share, John, about an experience at Johns Hopkins Hospital a few years ago. I was working with the wound care team at Hopkins, and they had just invested in a lot of new technologies for pressure injury prevention. And shortly after this change in their investment, they started seeing pressure injury rates going up. And they came to me in my office. Mind you, I don't do clinical care, so I didn't know about it until they brought it up with me. And they said, Bill, our rates are going up. I think all of this new technology we bought is garbage. I think we got to cancel our contracts and start over again. And I said, well, where's the problem happening? And they looked at me like, well, it's obviously happening in our hospital, Bill. And I asked them to dig a little deeper. Well, what unit is it happening on? What body parts are these pressure injuries occurring on? Is it the sacrum or the heels or the elbows or the back of the head or what? And they didn't know answers to any of those questions. So we sent them back to the drawing board, and what they found out is that the most pressure injury rates were happening in a specific surgical unit where patients were placed on their backside, and in fact, many pressure injuries were happening on the heels. And they had just invested in dressings that were on the sacrum, and they weren't getting any pressure injuries on the sacrum. So in fact, it wasn't that the technology that they had invested in was damaging or harming patients and creating more pressure injuries, but it was the lack of additional investment in technology that protected the heels specifically. And we found out which unit it was in, so we identified the exact type of patient that we needed to do more to prevent them on. And further investment in heel protection, boots and additional dressings and so forth, actually led to better outcomes across the entire hospital. But it was because of that very targeted data collection that they were able to make that pivot. And the key to data collection is it has to be prospective data collection. You can't just look back and try to put the puzzle pieces together. Starting with data collection today and moving forward allows you to explain in real time where the problem is, and being very specific about what unit of your hospital, about what body parts it's happening on. Those are examples in pressure injury care, but you could think of examples across the whole wound care spectrum where detail matters.
Thank you, Bill. Jamel, I'll ask you the same question. What do you do about data? I know that you're now in a new clinic setup. How have you started that off with data collection, and how are you looking at outcomes in the clinic?
Yeah, I mean, I think a good example would be to talk about the nurse-led wound clinic for the people experiencing homelessness that I established in London in Camden. So when, as Gunnar said, you do your homework beforehand. So it was quite clear from the evidence that we had lots of hospital admissions from skin and soft tissue and vascular injuries. So there was clearly a problem, but yet no specialist intervention for this particular marginalized group of people. So when I established the clinic, which was one nurse, me, very quickly I collected data around the demographics of the people, but also the outcomes of the clinic, such as quality of life, reduction in pain, improvement of mobility, wound reduction, exit area reduction, malodor reduction. And we were able, we're analysing the data at the minute, myself and one of the local vascular consultants. But data and collecting that for nurses is quite a challenge on a daily basis. And we're being asked more and more to actually incorporate this into our role as well as do everything else. What I will say to the nurses out there, it's really important that you embrace this aspect of the job. So collecting data and making it valuable. So it's something that I would suggest you work with your team. So if you're working in a vascular team, you connect with your vascular surgeon, or you connect with infectious diseases. So for me, I was able to prove that actually the nurse-led clinic was hugely cost effective. We had no hospital admissions at all for vascular-related injuries or wound infections out of all the patients that I've seen in a year, and one prescription for antibiotic therapy. So hopefully a paper out of that. But I think coming back to the role of the nurse in data collection, specifically for specialist wound clinics, it's hugely powerful. You've no idea, you cannot underestimate, but you may need to get some help to get you started up. But to actually be providing wound care and not collecting data, it's such a waste. So I think if you're out there and you have an interest in setting up new clinics or you're doing clinics, data collection is absolutely key.
Mohammed, you've obviously worked in vascular surgery for a number of years now, and you mentioned a few issues that you've had over the years and your experience of, like you said, where maybe if people are cutting costs, it can sometimes have long-term consequences. Have you had any experience of where value has been a discussion you've had and how you've improved outcomes?
Yeah, so I think, moving from one part of the world to another part of the world, or even just moving from one hospital to another, if you're developing a service or developing a service, it's a good time really to start looking at the data, auditing the data that proceeded where you've joined. And this is something that I thought first time about 10 years ago when I came, where the staffing across the multidisciplinary team for the diabetic was many members of the team weren't there. And also the length of stays and application was very high. And what we did, we looked at the actual data, recognized that it wasn't just length of stay, but readmission rates were high. And a number of variables picked up the first data collection audit, which was that patients were remaining for antibiotics, which maybe they weren't needing, to oral antibiotics. Some patients were being readmitted because when they left the hospital, they didn't access the care that they needed. So when you look at the outcome measure of, let's say, readmission or length of stay, one of the things that we were able to put together was the clinical guide, which wasn't just simply lifting a practice guideline from any of the international bodies and automatically using it, but it had to be tailored to the realistic environment that we're in. Then bringing a team members on board, that was quite the hard work, is getting all the members of the team that need to be involved. That includes finance, pharmacy, nursing teams. The wound care teams were predominantly led, no podiatrists at the time, and bring everybody together saying what we can do to improve. We certainly, with the practice guidelines, we were able to change very quickly empirical usage and antibiotic usage. What became very apparent is that, yes, we needed people who would view these patients, the outpatients, including podiatrists. We were able to business case for recruitment of podiatrists, which I have to say was one of the biggest that we were able to achieve. Point healing, looking at healing rates only or rates in hospitals, you'd have seen maybe it was okay. You saw what happened in terms of patients being readmitted. Then, of course, we had a dilemma, and that was something we definitely ought to take from and noted the improvement in reduction with readmission rates and reduction in the application rates within 10 months of implementing clinical practice guidelines.
So a true multidisciplinary effort then when it came to implementing that, and I think that's become apparent from some of the discussions we've had this morning in the Congress, that multidisciplinary approaches to, especially in diabetic foot care, are hugely beneficial for everyone. Kimberly, I'm coming to you next because as a former clinician, and obviously with some clinicians here and people who are responsible for the health economics of situations, what do we need to do to discuss with you or to kind of sell you that value message, or if we need new equipment that we know is going to prevent problems down the line or improve outcomes, what kind of communication do we need to have with you to kind of improve things and make sure that we are sourcing the right products and the right solutions for our patients?
So what's important is the data. I feel like I'm echoing, I apologize. We noticed that the data collection wasn't always uniform across our system, and making sure that everybody was collecting the same data. So we developed some criteria so that all the clinicians were, really capturing the same information. And it is important to see, if we're talking about wound care, like where is the wound care happening? What departments? Those areas to try to make the improvements. Because without the data, if you don't have data, you're not really sure what the problem is. So the data pretty much tells the story. And then when you come forward with the data, then you align it with the products and you say, and this is what the practice is going to be. And then trying to make it easier for the clinicians. The clinicians have time, but if they don't have the right products, it's going to take them longer to perform a task. If they're not applying the products correctly, then it's not going to give the effect of the patient. So for me, it's having the data, providing the education to the clinicians, and then reviewing the outcomes post, to see, take a look back. Is the product doing what it's supposed to be doing? And work with the vendors, work with the wound care nurses, the educators, and have like champions. And you also need a physician champion. So you could just really have a team to look at this and say that we're all aligned to get the same outcomes.
That's really helpful. I think, Bill, sorry.
I'd love to build on that, what Kimberly just said as well. The uniformity of data collection, it does matter. It is a lot of added effort, but starting with tools like using Excel spreadsheets that are made by one person as a master and then disseminated to different groups to use and to collect these data is important. And it's not just about outcomes that we should be collecting when it comes to value. It's also about clinical processes. Remember what we all abide by in the world of quality improvement: structure, process, outcomes, the classic Donabedian model. A structure like evidence-based guidelines need to be implemented consistently using the same process in order to achieve better outcomes. If you're measuring poor outcomes, it's probably because you don't have the right processes in place. So studying not just pressure injury rates, but how are we doing at repositioning consistently every 2 hours? Or how are we doing at skin checks and risk assessments on a daily basis for patients? Measuring those processes can teach us a lot about why our outcomes aren't going the way that we want them to. Then targeted improvement of those processes should yield better outcomes, and then you're finally getting at higher value healthcare.
Yeah, I think yesterday we had a discussion with the Cleveland Clinic, and they mentioned the S-Skin bundle, which is a really simple tool for measuring that you're doing the right things and you're doing them regularly for all your patients. And it's been around now for, I think, 15 years, and a number of places use it. And it's, like you say, it's measuring the process, not actually the outcome. But of course, hopefully it prevents a pressure ulcer, so therefore you get the outcome at the end.
I think that's important too, that there are cultural differences between healthcare facilities. So sometimes you have to start from scratch and building a tool that works well in your facility or in your health system. I just say with pressure injury prevention, the National Pressure Injury Advisory Panel has tried to produce some of these tools to make data collection uniform, like we have a root cause analysis toolkit so that you can do retrospective lookbacks and understand if a pressure injury happened, why did it happen? What in our process missed this opportunity to keep a patient safe from harm? So where those tools exist, like with the NPIAP, you're welcome to use those, but sometimes they don't fit well within the culture of a facility. So again, starting from scratch isn't a bad idea, or being creative, looking around, seeing what else is out there that might have been developed in another discipline that could be useful here. Nothing in statistics and in measurement is like reinventing the wheel now. There should be other things out there.
Yeah, thank you very much. So, Gulnaz, in terms of what we do now, what could we do in the future to try and make things better? So where do you want to be in 3 years with this kind of conversation? What should we be saying?
I think I need, what I want to do in next 3 years, I want to focus on community, and because I feel this is where we are not really doing well. So patient education, carers education, family education, and healthcare professional education. So everybody speaks the same language. So then we are all aligned. And when talking about data, so what we have done is we have implemented that into our system. So when at the end of the month, the system, we extract the data from the system. And then we compare with 7 facilities who is doing what. So we can see on a QLake how we are performing. So system is also very important, because we have done enough, one person is doing, in his way, and the other one is doing in his way, but system really makes a difference. So system, education, and patient first. Really important.
I'll throw that question to you, Jamel, as well. What do we want to be saying in 3 years' time that we've achieved? Is it using better data? Is it, like Gulnaz says, educating, a sense of community? What do we need to do?
I mean, for me personally, it's about more multidisciplinary working. So I'm very fortunate that I have direct links with the vascular consultant in London and know many of the teams here. And so we provide a one-stop shop where the patient comes, they see the consultant, they see me, we start the treatment straight away, they have the diagnosis, we arrange the scan or the intervention. And I think we need to be working more closely with our consultants and, on the broader scale of plastics and orthopedics. So I would like to see more one-stop shops, more multidisciplinary working. We have all the skill here in London to be able to do that, but I think with COVID, it's been quite difficult. So, the push for virtual consultation, I would like for that not to be lost, and that we need to get back to seeing patients face to face. I mean, there is a place for it, no doubt. But I think we need to remember that the real value is seeing the person, making that diagnosis and getting the treatment started, because, as the guest paper has told us, that's where the issue is with diagnosis and access to timely treatment. So in terms of where I see things in a few years, I think if we can improve the multidisciplinary working with specialist nurses, our consultants, and then our community teams, so that we're upskilling and feeding back, and of course the patient, including them. I think there's real value in that, but of course that takes investment and time to do that.
Excellent, and I totally agree with that one-stop shop idea and improving efficiency. If we can get everyone seeing patients that needs to see them quickly, then we can hopefully reduce the problems down the line. Mohammed, what about you, and what do you want to be doing in 3 years' time that's different, that you've changed from now?
What am I going to be doing in 3 years' time? But we'll probably stick to the diabetic foot discussion for me predominantly, and I think what I would hope would be more of a connected care. I think pretty much echoing what's been said already. I think understanding a little bit more of what patients looking for outcomes and changing from the concept of just simply healing equals satisfaction for the physicians in the hospital. We should be looking at functional outcomes for patients a little bit more, and should be implementing clinical practice guidelines across a network as opposed to individual silos. And I would hope that's something that we will be looking at. And sure, Gulnaz's team as well, who've mentioned about the ambulatory services and the outside community, I think that education level would be certainly helped and reduce some of those readmissions that we see as well. Thanks.
And the same question to you, Kimberly. What do you think should be happening in 3 years' time in terms of procurement and sourcing and services? What would you like to see changing? You've talked a lot about value-based healthcare and how you try and make decisions based on what you see are quality outcomes and not just cost, but there must be also cost pressures for you as well when you make these decisions.
Cost has been a challenge, especially during the pandemic. What I would like them to focus on is prevention, and that's where I feel, if we could prevent, then we would have better outcomes across all the board, and then patients, would be more satisfied. We also need to have consistency with patient care. We've had a lot of turnover, which I know that's not only in my organization, but in other organizations. So just having that consistency with staff and the practices, because when they come from different places, they might not have the same protocols in place. So it's just re-educating and offering that support to the team. And then also the last thing, which has been a big challenge, is the consistency of supplies. We've seen a lot of different supply challenges, which has caused us to bring in different products. And, just going back to, having regular products available that we were standardized to would help with all of the care that we provide to our patients.
Oh, thank you. Bill?
Yeah, I love what Gulnaz said about engaging patients and families. The truth to this whole field of wound care is that most of the time, patients don't even have a clue what they're at risk for. Ask a patient who's having a hip replacement procedure or CABG or anything for that matter, who's going to be laying in bed in a hospital for the next 5 days about their risk of pressure injury. They've never even heard of it, right? If you could communicate to patients or their family how much is at stake, not just for the recovery from the procedure, but from the risk of pressure injury, then maybe they'd take that risk more seriously and do more to mitigate it themselves. Say, today I'm going to try to get out of bed and not just lay in bed and watch TV all day and let the nurse and the doctor do all the work. Yeah. And so I think that is an enormous potential area of engagement that adds value. Because let's face it, we haven't achieved zero in anything in wound care that we've wanted to. There's still pressure injuries, there's still DFUs, there's still amputations, there's still people dying. In the United States last year, over 60,000 people died of pressure injury related causes. That's the size of a whole city. We're talking about serious consequences in a national emergency that probably is consistent not just in the US but across most countries in the world. And so what haven't we done yet? We haven't engaged the patient and the family caregiver in the right care to prevent some of these negative outcomes, and I think doing that could take us to the next level. We are actually at the National Pressure Injury Advisory Panel trying something new where we've established a patient advisory council. And so for the first time moving forward, as we produce and publish new guidelines for pressure injury prevention and treatment in the future, patients will be engaged as stakeholders in the development of those guidelines and also help us to think about what are the educational materials that we can produce to make those guidelines translatable to patients and family caregivers. Now that's a national or global effort, obviously, because the international guideline is part NPIAP, it's part EPUAP, and it's part PPPIA, all members of the World Union. But there are grassroots efforts that need to happen locally, because the NPIAP can publish some sort of educational material to engage patients in English, but there's still several hundred other languages out there where this isn't going to be translated. So what you can do locally to think about who is the population of people that you're giving care to, and how could you educate your local community in improving outcomes that matter here in the wound care space, I think that it could have a huge impact.
Thank you, Bill. Gulnaz, a question for you. What can industry do to help?
Well, industries always have to help. I'm kidding. Yeah. So, I mean, support from industry is like bringing the evidence, So just to make our, like for me, for my example, if I have to have something new in my facility, I need the evidence. That's the first thing I need to attach to my documents. And then what I need next is, that's not for me though, but that's for procurement. They want to know the cost. But then if my evidence is strong, then cost doesn't matter, but sometimes it matters. So then I need to see how easy it will be for the patient to use, and then that again make my case strong. So, there are different things which we need to look into it, and then which patient, what kind of wound I'm using what. So you need to really look into healable, non-healable, or maintenance. Yeah. So you make your plan according to that. Then you are in a win-win situation. You don't waste, but you really think. And when you choose something, you need to know where you are putting it, or on who or which wound you are using it.
Yeah. So the evidence is important, but also the practical solutions are important as well. So making sure they fit for the individual patient. You can't just give one size fits all. Really important. Yeah. So we're almost at the end of our session, and I'm just kind of trying to look at all. I made loads of notes here, and they're not in any particular order. But we've started a value discussion, and we talked about the importance of guidelines. We talked about the importance of collecting data. We talked about the importance of how we need to discuss solutions with procurement. We need to give them more information, as Kimberly said, give them more information, and then they can make better decisions, and I think that's huge. Bill talked a lot about, in terms of the process, like measuring processes, not just measuring the outcome at the end of the day. And I think we've covered quite a lot of stuff there. We've covered the multidisciplinary team, one-stop shop care, improved efficiency in care. Everything comes in there. It all brings in, it becomes part of that value discussion. So I think it's been huge. We've covered a lot of ground. Is there any questions from the audience before we finish up today for any of the people here? We've got a question here, Sarah.
Do we have some microphones?
We have a mic somewhere. Oh, there we are.
Yeah, it works. Can you hear me from here?
Yeah.
Okay, thank you very much. You were approaching the value-based healthcare from a health economy point of view and also from a data collection point of view. But the most important outcome in value-based healthcare is the patient-reported outcome. So if we know what the preferences of the patient are regarding what they consider important as outcome and consider important regarding the treatment choice, then we would be good on our way to value-based healthcare. And this aspect of taking into account the patient preferences is shared decision making. And I did miss that in your discussion. So what does the panel think of shared decision making as an essential part of value-based healthcare?
I think it fits in well with a lot of what we're talking about today, that value is best determined by what the patient wants to achieve in terms of their outcome. And so talking to the patient before they undergo a procedure, perhaps to prevent something, it really does matter. Recently, David Armstrong and I and some other colleagues started looking at decision models for early ablation versus later ablation with compression therapy for venous leg ulcers. That's not necessarily something that everybody wants to take their chances on because that requires an upfront procedure. It's preventive, but you're going under the knife today versus waiting several months and seeing can compression therapy work, or is this going to get work and inevitably I'll have to go through it? So those are value-based decisions that we have to make, that sometimes when the patient gets the outcome that they want, then they actually have a better outcome overall.
Yeah. I would like to submit that it's not only talking to the patients, but asking from them what they think is important for their life and for their health.
It's a very good point.
I fully agree. That's great.
Jamel, have you got anything to say on that? I know it's close to your heart, that subject.
Yeah, I mean, I completely agree. For me, it's the key to engaging with the individual. It's the key to be able to share that decision, to understand the people that we care for, to listen to their story, and what matters to them. I mean, healing is not just the physical, and we know that the patients that we work with live very complicated lives in a complicated world. So, you know, there are many different levels of that therapeutic healing as well as the physical healing of the wound. And that shared decision making is fundamental in building that relationship between, I suppose, everyone really, but particularly the clinician and the patient and their families.
Thank you for that. Do we have any other questions? I know we're almost out of time, so I just want to say thank you very much to our speakers who are here, to Bill and Gulnaz, and also to the speakers online. Apologies for the technical issues that we had, but I'm glad we got there in the end. And I thank you. I hope you have an amazing Congress. I hope you enjoy the rest of the week. And it's been nice to meet you all, and thank you for coming. Thank you.
Thank you. Thank you.
Thank you. Thank you.